Okay, guys, welcome back. We're going to go into distributive shock now. Distributive shock is a result of widespread dilation of these small arterioles, or small venules, and or both. Okay, this is widespread vasal and arterial dilation. We have a good pump. We have fluid. However, our pipes are too big in order to maintain the pressure to keep the pump and the fluid happy and circulating effectively. Obviously, if our pumps get too big, we're not able to keep the perfusion pressures that we need, so our tissue perfusion will decrease. We're not able to get those gases, specifically oxygen and CO2, in the process of diffusion in order for them to have that good pressure in order for them to diffuse appropriately across the membranes that they need to cross. The big one with distributive shock is septic shock, also known as sepsis. Extremely hot topic nowadays in the world of medicine. We are really trying to focus in combating this as best as possible. And from my understanding, this is not a pleasant way to go. And unfortunately, this is probably one of the more common shocks that we come into contact with, both in EMS and really in medicine in general. Basically, septic shock occurs as a result of a severe infection in which the toxins are generated by bacteria or by infected body tissues themselves. Okay? Anytime that you guys get an infection, that infection can lead to a septic shock if it's not treated. All right. The problem is that the toxins will actually start to build up in our blood, build up in our plasma, and really those toxins are coming from the infection themselves, which could be destroying our intercellular fluid and kind of spilling out all the nastiness that's found within our cells. But really what it's doing is it is damaging the walls of our vessels. Okay, it's kind of slowly eating them away, and this causes increased cellular permeability. So because we are eating away at our cells, we're killing our cells much faster, really kind of spilling out all that nasty acids that are contained within our cells, and this process just starts to cascade, and this process can happen very fast, and we could develop septic shock systemically real quick, and the vessel walls will actually start to leak. They'll actually start to kind of third space their fluid. We'll see these patients kind of really start to become bloated and whatnot, and they will not be able to constrict as good as they could have before they were introduced to this infection. So this is a kind of a process of the of shock that is very not pleasant for our patients to be suffering from. So again, the best way to define septic shock, also known as sepsis, is just the widespread dilation of vessels in combination with the plasma loss through the vessel walls. This results in shock. Okay, so we have this huge widespread vasodilation. Our pipes are getting too big, and because our pipes are getting too big, our plasma actually starts to leak out of these pipes because of the cellular permeability, and we are now also going into a hypovolemic shock because we're actually starting to lose fluid. So it's basically two different types of shock in one. It's a distributive and a hypovolemic because we're losing so much fluid. And we'll talk about hypovolemic shock here in a sec. Another form of distributive shock is neurogenic shock, and this is usually as a result from a spinal cord injury, specifically a higher up spinal cord injury. We're talking cervical spine, or really kind of any part of the spine can result in a neurogenic shock. But we can really see it affect our patients more higher up on the spine that we go. This can be caused by some kind of abnormality in the brain, right? Whether it's abnormal growth, such as like a tumor, or we have significant lesions on the brain due to infections of the brain, right? We see this a lot with, could be IV drug users, right? They can actually get an infection of the brain for people that like to shoot up their medications and use dirty needles. This can be caused by pressure on the spinal cord and spina bifida. And we're going to talk about spina bifida when we get into our neonatal section a little bit more. But neurogenic shock, when it comes to it, again, the muscles and the blood vessels are actually cut off, right? We have severed our spinal cord. So the muscles are cut off from the nerve impulse, which they can no longer contract. So they stay vasodilated, okay? And when we see, specifically when we're talking about a spinal cord injury, I've seen it once. Specifically, I've seen it once in my time in EMS when I was on the streets. But you have this kind of line of demarcation across their body from wherever the actual spinal cord was actually cut, right? So the level above, right? Let me make sure I'm saying this right. The level above the actual line, they were warm, pink, and dry. The level below, they were pale, cool, and sweaty, right? Because the body has stopped talking. The upper half of the body stopped talking to the lower half of the body, right? So it's kind of a weird phenomenon. You guys can look it up online for neurogenic shock. And I think there's some good pictures for you guys also in your book on neurogenic shock. But make sure that you guys read up and kind of Google a little bit with distributive shock, specifically neurogenic shock. So again, we have suffered some kind of spinal cord damage, and the muscles and the blood vessels walls are cut off from that nerve impulse that caused them to contract, right? So wherever the actual spinal cord damage is, this one's kind of pointing to this neck of this patient here. He'll be warm, pink, and dry above that level, and everything below that, he'll be pale, cool, and clammy, because all the vessels are dilated because they're no longer able to contract because the blood vessels have lost the nerve impulse due to the spinal cord being cut, right? So they will, you can see the normal vessels there compared to the dilated vessels, and more than likely, we're not going to have a good outcome for our patients when we do see neurogenic shock. Anaphylactic shock, we already covered a little bit also in our respiratory lecture. Anaphylaxis is a beast, guys. Yes, it is considered a distributive shock. However, during the process of the actual anaphylactic reaction itself, we actually have a couple different shocks kind of thrown in there. It's got a little bit of hypovolemia in it. It's got a little bit of cardiogenic. It could have a little bit of obstructive, but really this is a distributive shock due to the widespread vasodilation of the patient's vessels. Again, this occurs when a patient reacts violently to a substance to which he or she has been sensitized to. They have been introduced at some point in their life to an antigen. Their bodies have developed antibodies in order to fight the antigen, and for whatever reason, remember, we got all those mast cells that start to degranulize and release of the histamine, and it just starts this whole cascade from top to bottom. And yes, this is definitely, without a doubt, a serious life threat. Okay. Sensitization means becoming sensitive to a substance that did not initially cause a reaction, right? And remember, you guys can develop an allergy to anything at any time in your life, okay? You guys can be sitting there enjoying your watermelon one summer, and then the next summer you enjoy your watermelon, and all of a sudden you almost die, right? Because your tongue swells up and you just have this whole widespread vasodilation going on. That's what an anaphylactic reaction is. All right. Each subsequent exposure will tend to lead to a more severe action. All right. And unfortunately, there's people out there that do suffer allergic reactions, and they keep eating the substance or exposing themselves to the substance over and over and over again. Maybe they can't quit the substance, right? Or they just are uneducated about it, or you could have these like really small allergic reactions to stuff and really not even know it, right? And then all of a sudden you eat it again and you just boom, you just have this huge widespread anaphylactic reaction. So again, you guys can become allergic to anything at any time in your life. So when we're talking about anaphylactic shock, we kind of break it down into 4 categories of actual exposure. We're going to talk about injections, specifically like immunizations or medications that people might take. Stingers, specifically from wasps and bees and hornets and ants, right? Those seem to be the big ones with the stingers. I would also specifically out in our region throw in scorpions. They can have an anaphylactic reaction from that. Ingestion, you guys accidentally ate something that you're allergic to. The big ones are certain kinds of fish, specifically shellfish, nuts, eggs, and again, medications that could possibly have one of those components in the medication. And then inhalation is your basic kind of allergic reaction. Your allergies, remember, is a focused or localized allergic reaction. Dust, pollen, mold, pet dander. Some people react to perfumes. Some people react to smoke. Like some people can technically be allergic to cigarette smoke. So again, the big life threat with anaphylaxis is that this can happen extremely quickly. Your body is very efficient at recognizing threats, specifically things that you are allergic to, and it just again starts a cascade that the body thinks it's doing itself good, and it's actually really causing itself more harm. Anaphylactic shock can literally happen within seconds. And again, this is something that we usually get called to, and we are way, way, way behind the 8 ball. So you guys need to be aggressive with your treatments, right? Let's get them some oxygen. Let's give them a shot of epinephrine right off the bat, right? Right off the bat. And then instantly, don't reassess. This is the only time I'm going to tell you guys not to reassess your patient. Give them that shot of epinephrine. Let's get them started on that duoneb with albuterol and ipratropium. And then we can start reassessing our patient once we kind of get those 3 main drugs on board. And make sure you get off scene quickly. Okay? Get them to the hospital. Meet up with an ILS, ALS unit, whichever one's closer. And let's see if we can stabilize this patient, because even your intermediates have a lot more that they can play with. Not as much as the medics, right? But the intermediates definitely have some drugs that they could use in order to help your patient out. But make sure that we are recognizing this and that we are going to get off scene as soon as we can. Okay? So it develops within minutes or even seconds of contact with the substance. There can also be what's known as a rebound anaphylaxis, which is a second phase of reaction that can occur 1 to 8 hours after the initial reaction. So these people have to go to the hospital. These people have to be monitored for quite some time to make sure that second phase of reaction doesn't come. Because the problem is that second phase is much worse than the first phase. Okay? There are some very distinct signs. We talked about this already. The urticaria, right? Hives, angioedema, swelling to the face, mouth, lips, tongue. You guys might hear stridor. They might be itchy, right? They're going to be restless. They're going to be anxious. They're going to be pale. They're going to be sweaty. They're going to have an elevated heart rate. There's all kinds of signs for this. Okay, we have to be able to recognize them and start treating accordingly. We can see cyanosis, which is that bluish discoloration of the skin. If we see cyanosis during a anaphylactic shock, guys, we are in trouble. Your patient is in trouble. Okay, that means that we are having a problem with the Fick principles. We're having more than likely problems with ventilation. We might not be able to get that air in and out of our lungs. The air that we are getting in and out of our lungs might not be doing respiration. We might not be able to provide gas exchange. Because our throats are closing up, we're going into an obstructive shock. Because we're going into an obstructive shock, our heart's going to work harder. Our heart's going to beat faster. Okay, we're going to significantly decrease our cardiac output because our heart is beating too fast, because we are not able to get into all the blood back from our body into the heart, because everything's kind of starting to swell down. Eventually, our heart's going to keep pumping and faster and faster and faster. We're going to run out of energy. We're going to go into a cardiogenic shock, and more than likely, your patient is going to die. So we got a little bit of distributive because we got widespread vasodilation. We got a little bit of obstructive because everything's swelling, specifically our patient's airway. So we're messing with Fic 1 and Fic 2. And then we're going to start messing with Fic 3 because our heart's going to become tired, and more than likely it's going to stop on us. Okay? Nasty stuff, guys. Okay? Anaphylaxis is, it's a beast. And it's a beast that we need to be able to recognize, and it's a beast that we have to be able to slay and conquer, or we're going to have very bad outcomes for our patients. Okay, I did skip ahead on a slide. You guys do have a chart in your book. I believe it's table 12-2 in your book. This is the signs and symptoms of anaphylactic shock. Kind of breaks it down into skin, circulatory, and respiratory system, and some other stuff. Make sure that you guys are looking over that when you guys are doing your readings in your book. It is a good slide. It's got a lot of information on there for you guys. Make sure you guys are studying up on that. Okay, our last form of distributive shock is actually psychogenic shock. And I think that psychogenic shock kind of has a bad name in medicine. I feel that, at least with some of the docs that I know, they really don't feel that this should be considered a type of shock. But really, when you're looking at the pathophysiology and what's going on in the body, when somebody is in psychogenic shock, it is a distributive shock. We do have widespread vasodilation. Now, it is reversible. Okay, and it is very quickly reversible. And basically, these are the people that suffer from anxiety attacks or panic attacks, okay, where they just breathe so fast and their heart's not able to pump all that oxygen-rich blood, right, because we are retaining CO2 and we are naturally causing a widespread vasodilation. But this is caused by a sudden reaction of the nervous system. Okay, whether it's stress-induced, whether it's whether it's stress-induced or not, either way, it is a sudden reaction by the nervous system. It produces a temporary, generalized vascular dilation. Okay, so the key word there is temporary. All right. Because they're breathing so fast, because they're retaining CO2, because they're not able to blow off that CO2 because they're breathing so fast, this can result in syncope. The patient goes and passes out. And again, this is like the brain's way of doing its own Control-Alt-Delete. It's going to reset the programs. That patient's going to come back to, and hopefully they are breathing normally again. Okay? Yeah, there are some serious causes to this, okay? And there are some things that we can do to help our patients. We already talked about hyperventilation in our respiratory lecture, but there are some causes to this as well that could be metabolic causes, changes in electrolytes. Sometimes our diabetics can go into a psychogenic shock. It could be because of a tumor in somebody's brain. It could be because of some kind of undiagnosed malformation of the actual brain structure itself. Again, guys, we are planning for the worst and we're hoping for the best. Not all panic attacks are stress related, okay? Well, this could be because of some kind of irregular heartbeat. Again, some kind of electrolyte imbalance. This could be a brain aneurysm. We're going to talk about brain aneurysms a little bit more when we get into neurologic emergencies. But really, the non-life-threatening events include stress-related. Somebody just got some bad news, right? Somebody experienced some significant amount of fear or some kind of unpleasant sights. A lot of people cannot stand to see their own blood, right? And because of that, they pass out, right? Somebody might have witnessed a terrible event, and the body just can't take it. Their brain says, "What is going on? Did I really just see that?" Control-Alt-Delete, we're going to pass out for a little bit and see if this is actually real or not. Okay, guys, so that is the last of distributive shock lecture points. I do have a picture again for you guys to kind of put this into play coming up next here, so you guys can get a visual of this. Okay, so here is your visual. As you guys can see, our pump is good. All right. Our container is the same size. We have the same amount of blood that we always did. However, our pipes are too dilated. Our pipes are too big. So it makes it look like our container is running low, and it is. Because we have the same amount of blood, because our heart's pumping effectively, because our pipes are too big, we are not able to create the pressure that we need in order to provide adequate perfusion, also known as gas exchange, to our cells. Our lungs are working fine. Our heart's working fine. We're getting good respiration, right? We're getting good gas exchange within our lungs at the alveoli level, but we're not getting the perfusion that we need because we do not have the pressure because our pipes are too big for the amount of fluid that we have. We have the same amount of fluid. Our pipes are just too big, so we're not able to create that pressure. Again, I kind of broke this down for you. Again, remember that the blood volume is not decreased. Our container size has increased because our pipes have got really big. They have dilated. You guys have all the lists of causes there for distributive shock. Another little caveat, another little side note I want to put on this. You might see distributive shock, also called redistributive shock. They mean the exact same thing, guys. Okay? Redistributive and distributive are the exact same things. We don't really talk too much about redistributive shock at the basic level. There are a couple differences, but you might see it referred to in your book as redistributive. If they say redistributive, they're only talking about distributive shock. Okay? We do have another lecture on shock. I believe we're going to go into hypovolemic shock next. And I will see you in that lecture. Please email me if you guys have questions. Take it easy, guys. We'll see you next time.